Good morning. This is Dr. John Bennett from beautiful Miami Beach, home of Neurosurgical TV. We have the honor of having the king of Zoom. When I say that in an admiring way, Atul goes all over the world. He teaches evidence-based medicine. He's written it probably the most of any neurosurgeon in the world. And for this webcast, I'd like to introduce Takashi K, a neurosurgeon from Tokyo. Welcome, Takashi.
Good evening, everyone. So I'm Dr. Takashi K from Tokyo, Japan, Showa University. It's a great honor for me to introduce Dr. Atul Goel in Mumbai, India. He's a king of neurosurgery and I'm emeritus professor of Department of Neurosurgery, King Edward Memorial Hospital. And in Japan, he was in Shinshu University in Japan. He contributed a lot to the Japanese Neurosurgical Society. Shinshu University, Dr. Kobayashi and Dr. Hongo, he wrote many papers and many contributed to Japanese neurosurgeons. Today, he gave the lecture about central or axial Atlantoaxial instability, a futuristic concept. It's a great honor for me to get a great lecture of Dr. Goel, Atul Goel. Dr. Atul Goel, please.
Thank you, Takashi. Thank you, John. And thank you, my dear friends. Let me get my slides on.
Okay, perfect.
Okay, so you know what, John, Japan has been one of my very favorite countries for a very, very long time. You will be surprised that on my passport, there are more than 50 entries to Japan, more than 50. So many times I have been to Japan, I have got so many wonderful friends. And as Takashi mentioned, I was in Shinshu University for a period of time where I wrote a book with Professor Kobayashi and Dr. Hongo. And many good Japanese friends of mine are my property of my life. And Takashi, you'll be also happy to know that next week, we are having a very important Indo-Japan celebration in India, where more than 25 senior Japanese neurosurgeons are coming to India. And we will have an Indo-Japan friendship meeting. So this is one big meeting that we are having. And I wish that you could have also joined us on Thursday. So I'm going to discuss and talk about a very important subject of neurosurgery and spine surgery. This subject is on craniovertebral junction instability. Atlantoaxial joint is the most mobile joint. Atlantoaxial joint is the most unstable joint. Atlantoaxial instability is the most common instability of the spine. Atlantoaxial instability is the most under-recognized and under-treated instability of the spine. To treat atlantoaxial instability is not easy. However, if you treat it properly and you treat it effectively, you treat it solidly, you give new life to these patients. And we have to learn to give new life to these patients. Craniovertebral junction instability is still being understood. I don't think it has yet, the last word has been said about understanding craniovertebral junction instability. So let me try to bring some newer perspectives to craniovertebral junction instability. First and foremost, in spine surgery, whenever we talk of spine surgery, whenever we talk of craniovertebral junction instability, whenever we talk of spinal instability, spinal degeneration, spinal OPLL, disc herniation, Chiari malformation, syringomyelia, basilar invagination, whenever we talk of anything in spine, we talk of compression. And we talk of decompression as the treatment. So compression is the issue in spine surgery. For majority of issues in spine surgery, we talk of compression. and we talk of decompression as the treatment. I wish to completely change this concept and take you to a different world of spine. That compression, of course, tumors are a different issue, tumors are a different problem. Compression is never an issue in spine surgery. And decompression is never the treatment. So it is a huge and quite a revolutionary kind of concept, which I have been talking about for a period of time for more than 15 years. Some people have started following me, but I wish to take this message down and deep in the remotest of all corners of the world, and of course to my most favorite country, Japan. So the topic is, today my first chapter of my topic will be about craniovertebral junction. Next week, I will be talking on subaxial spine. The issue will remain same in both these topics, that compression, don't do decompression. Whenever we talk of compression, it indicates an unstable spine. Compression is never primary. Compression is always secondary to unstable spine. Compression always indicates instability. Compression is always a naturally protective or adaptive phenomenon. And compression is always reversible following stabilization. And decompression is never the treatment. So that main premise of mine, I will like to take you over. Subaxial spine. You see, all our muscles are located in the back of the spine. I will discuss the issue of vertical spinal instability due to muscle weakness of the subaxial spine. And I will talk on the subject of spondylosis, degenerative spine, single level degeneration, multiple level degeneration, disc herniation, OPLL, and several other phenomena where we find that decompression is the considered treatment the world over. This term, the vertical spinal instability, is a brand new term in neurosurgery and spine surgery. It indicates that there is a listhesis at the facets, and this listhesis of the facets may not be recognizable on imaging, on dynamic imaging. So this I will discuss in the next phase of my discussion. Today, I want to discuss the issue of central or axial atlantoaxial instability. In my belief, in my complete understanding, and my experience over several years, maybe over 40 years on this subject, I am convinced that this understanding of this fact can completely revolutionize craniovertebral junction surgery. So prepare, my dear friends, from Japan and from elsewhere to have a pleasure of understanding this new futuristic overview of craniovertebral junction, central or axial atlantoaxial instability. As I have discussed on several occasions in my life, in my multiple lectures on craniovertebral junction surgery, that craniovertebral junction surgery is not easy, it's dangerous. These kind of, and I have got the advantage of treating most complex issues in craniovertebral junction surgery over a period of time, such deformation, short neck, torticollis, bony abnormalities, vascular abnormalities, so all kinds of abnormalities pose a very difficult challenge for a neurosurgeon. But if you can treat it, you can give a brand new, fantastically new life to these patients. And if you don't treat it properly, short neck is one thing, and torticollis is one thing, you can completely demolish the person. You can create quadriplegia, you can create respiratory disturbances, and a whole lot of problems you can create. So from complete new life to complete devastation, and this depends on our learning. And understanding this beautiful junctional bones, these two bones are the most magical bones of the body. Transverse process is the largest transverse process of the atlas. Facets of atlas are the largest facets of the entire spine. The odontoid process is one unique bone of the C2. Spinous process of the C2 is the largest spinous process of the C2 of the whole spine. Atlantoaxial joint is the most mobile joint of the body. So there are too many beautiful things in the craniovertebral junction. Another thing is the facets of C2 are very closely related to the vertebral artery like no other facet in the spine. And the facets of C2 are unique. The superior facet is in front of the inferior facet, not in one line. Like here, the C1 facets are in one line, superior, inferior. But here, the superior facet is in front and the inferior facet is behind. So it is a unique set of both. Many of you who are interested in craniovertebral junction know this technique for a long period of time. I described in 1988 as a very young consultant in neurosurgery, introduction of screws in the facets. Facets are the strongest bones of the body, of the spinal vertebra. It is not the vertebral body, it is not the pedicle, it is not the transverse process, it is not the lamina, but the facets which are the strongest. So introduction of the screw in the facet of C1, facet of C2. This technique we described in 1988. And now, of course, this technique is followed throughout the world. And many people in Japan have written some wonderful articles on this subject. So my technique involves use of the facets. Facets form the fulcrum of all spinal movements. Takashi, can you understand me, Takashi?
Yeah. Yes.
So should I go a little bit slower?
It's okay.
Okay.
Yes.
So facets of the atlas and facets of the axis are the largest and strongest of the whole spine. If you put the screw in the facet, they give a very firm and strong purchase to the screw so that you can have a very solid fixation. So this technique we described in 1994. My technique since 1994, as I have talked so many times in my lectures, involve three main steps. One is I open the joint. Second step of mine is removal of the articular cartilage or denuding of the articular cartilage. Third step involves putting bone graft in the facet, bone graft. So these three steps are very important, critical, and crucial in my understanding. And then I put one screw in the C1, one screw in C2, and then a plate. And you can put a rod if you are more comfortable with rod. I used to do occipito-cervical fixation for a long period of time to be also described in 1987. Screws in the occipital bone to fix the occipito-cervical implant. So screws we describe. But as we grow further in our business of craniovertebral junction, we realize that craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. Occipito-atlantal instability is extremely uncommon. So there is no need to put occipital fixation. So whenever we do craniovertebral junction stabilization, we should do atlantoaxial stabilization. Occipital bone inclusion is not necessary. It is actually counter-effective in craniovertebral junction because occipito-atlantal joint is the most stable and the strongest joint of the body. Very, very rarely in the highest degree of trauma, you can get occipito-atlantal instability. And in some syndromic children, you can get occipito-atlantal instability. Otherwise, occipito-atlantal instability is extremely common, and you should learn to do atlantoaxial fixation. So this was my first fixation in 1988. One screw in C1, one screw in C2. You see, I have not included the occipital bone in the fixation construct. It is only atlantoaxial fixation. So over the years since 1988, I was very fortunate that I worked in a public institution, a teaching institution all my life. And in these so many years, we have developed and experienced nearing 4,000 cases of C1, C2 fixation using this technique, 4,000. So one screw in C1, one screw in C2. This is the technique. And we have used in infant, this is a 6 months old infant. We have used in 90-year-old gentlemen. And so in all ages, the facets are the strongest. You might have problem with the arch of atlas. You might have problem with any other bone. But the facets are continued. They are the strongest. So you can use in an infant. You can use in very small children. So the most beautiful thing that we described about craniovertebral junction anatomy was that the C2 ganglion is located behind the C1, C2 facet. C2 ganglion is located outside the spinal canal, like no other ganglion of the body. C2 ganglion is located behind the atlantoaxial articulation. You remove the ganglion, you can expose the atlantoaxial joint. So this is what we described in 1988. We said that you cut the ganglion and you can have a window to the atlantoaxial joint. But nowadays, of course, I don't cut the ganglion in majority of my cases. I mobilize it up or I mobilize it down. More often, I work under the ganglion. I work in this direction, under the ganglion, not under the arch of atlas directly. Under the ganglion, then I reach the joint, and then I reach the facet in majority of my cases. But nowadays, as I have said, I don't do C2 ganglion resection. Vertebral artery has got very intimate relationship to the C2 ganglion. And we described in this paper that the vertebral artery, when you move the neck, the vertebral artery moves. And you move to the right side, vertebral artery moves like this. So there is a dynamic phenomenon. So this vertebral artery groove may not be completely occupied. This groove that you see on CT scan may not be completely occupied in neutral position, like in this situation. It moves. So this space is occupied by large venous complex in this region. So more important issue in putting the screw in the C2 vertebra is the issue of vertebral artery. So you should select 9 quadrants and put the screw in the uppermost quadrant here. That is the safest. Of course, you can use navigation, you can use all kinds of equipment, and the C2 screw should be up and medial, up and medial. That is the main issue in the C1, C2 plate and screw fixation. I used navigation for a period of time in my career, but now more often than not, it is not necessary. What is necessary is to have a clear view of CT scan, a clear view of CT angiography, clear view of coronal imaging of CT scan, identifying the vertebral artery, and then going in the medial quadrant. So vertebral artery is one issue. Venous territory, large venous complexes is another issue. C2 ganglion is another issue. So a few years ago, we described 3-dimensional models as a preoperative investigation for craniovertebral junction surgery. 3-dimensional models. So we can hold the model in our hands. So this is a model. 3-dimensional CT scan is one thing. Model is another thing with vertebral artery. So you can hold the model in your hand. You see there is a complex anomaly of the vertebral artery. So you can completely identify the vertebral artery holding the bones. These models become very important during surgery, particularly to save the vertebral artery, to identify the direction of the screw, to preoperatively plan the size of the screw. You can teach your residents, you can discuss at length. So preoperative models are very important. You see, this is a vertebral artery, is quite in a dangerous kind of situation in this patient. The pedicle is very, very thin. This is the vertebral artery groove. So, and the vertebral artery is going behind the C1 facet. So these are very complex anomaly. How to put screw, where to put screw are issues. And this 3D model can help you in making that. Another thing is, as I've said, the C2 facets are a little bit peculiar. C2, the superior facet is in front and the inferior facet is behind and the pedicle is here. So you can put your screw like this, but sometimes this vertebral artery can be in a very difficult situation. So we have described that you can put your screw in the inferior facet here. One screw in C1 and the C2 screw in the inferior facet of the C2. So this is the article where we said that this inferior facet of C2 can be a useful terrain to introduce your screw. Of course, the best thing is to put the pedicle and the facet screw. If you see this, the vertebral artery is quite high, and somehow it was not possible to put the C2 screw. Then I used the inferior facet to introduce this. This can be used on a rare occasion. Of course, this is not a very common kind of thing. Another thing is the vertebral artery can be mobilized. This is also an important surgical step, like we talked about this step in this article of mine. You drill the vertebral artery groove and then mobilize the artery. Like in this, the vertebral artery groove is very big. You cannot put your screw. Here, the vertebral artery groove is very, very deep and high. So we have mobilized the vertebral artery and introduced the screw. You see, this is the vertebral artery, and the screw grows above the vertebral artery. We can use the spinous process. I described this long time ago in 2004, the spinous process screws. We can also use laminar screws. This is also I described in this article. Laminar screws and spinous process screws can be used as a C2 fixation. So this is my screw fixation very long time ago. I never used laminar screws or spinous process screws or spinal laminar screws now. We also described intra-articular spacers. You see these spacers, these metal jammers, as to stabilize the atlantoaxial joint. I must say that these spacers have been patented by me, but I don't use them too often nowadays. So the indications and the techniques of use of facetal distraction spacers in my own personal view has changed over the period of time. I depend on C1 fixation. Even if it is most dangerous or most difficult, I try C1 facetal fixation, even when it is assimilated atlas or whatever. And in rare situation, I use transcranial method of atlas facetal screw fixation. You see this, this is quite a high craniovertebral junction, quite rosterly located. And I did a smallish little craniectomy here. There is a craniectomy to get into the C1 and then into C2. So transcranial insertion of C1 facetal screws. If you realize, you see so thin, this occipital bone is so thin, I can use occipitocervical fixation. But this is so thick and strong, and this is thin, and you can have a difficult situation in the postoperative period. The most important change in the craniovertebral junction, or the revolution in craniovertebral junction, came with the understanding that there is nothing like fixed dislocation. There is nothing like fixed atlantoaxial. You can open the joint, manipulate the facet, and reduce. Instability is the issue in craniovertebral junction. Instability is the problem in craniovertebral junction. Instability causes the symptoms in craniovertebral junction, and stabilization is the treatment. So this completely revolutionized craniovertebral junction surgery. So this kind of case, for several years, transoral decompression was the treatment. But if you learn the anatomy, learn the technique, open the joint, distract the facet, manipulate the facet, reduce the dislocation, stabilize the joint, that is the treatment. Decompression is not the treatment. And now we have got several hundred cases where we have done facetal manipulation and decompression has been completely removed from my story of craniovertebral junction. In very severe trauma, when the whole joint is disrupted, you can manually manipulate the facet and reduce the dislocation. Rotatory dislocation, nobody knew how to handle rotatory dislocation, but you can maneuver the joint, open the joint, maneuver the facets, reduce the dislocation. And my understanding is clear that this concept completely changed the treatment of rotatory dislocation. Otherwise, nobody in the world knew how to treat rotatory dislocation. Only traction or some kind of maneuvering and things like that were being done. Rheumatoid arthritis, distraction, reduction completely changed the story of rheumatoid arthritis. Otherwise, this PANAS, the whole world was treating PANAS by decompression. The whole world was doing compression by decompression. But I have no hesitation to say that this concept completely revolutionized treatment of rheumatoid arthritis, and this kind of vertical instability in rheumatoid arthritis due to destruction of the facet, open the joint, distract the facet, realign. Whether the realignment is complete or incomplete does not matter. Instability is the issue and stabilization is the treatment. So this was my article long time ago on rheumatoid arthritis, now a quite well cited article in the literature. Essentially what I'm saying is complete revolution in rheumatoid arthritis. Basilar invagination, not many people in the world knew how to treat basilar invagination. In 1998, we described basilar invagination into two types. One is when the odontoid process goes up, and the second is when the tonsil herniates down. So treatment for basilar invagination, group A was do transoral decompression. Group B was foramen magnum decompression. So decompression was the treatment for both group A and group B. Then what we said is in 2004, that group A, where the odontoid is going up, there is vertical instability. Open the facet, distract the facet, reduce, and you can do craniovertebral junction realignment. So we said for group A, decompression is not the treatment. In 2004, we said for group B, foramen magnum decompression is the treatment. So this is what we said. So this kind of basilar invagination, open the joint, distract the facet and reduce, and you can do a beautiful, more important than reduction, more important than realignment is the stabilization. Instability is the issue. As soon as you touch the bone, you will feel the whole thing is unstable. Open the joint, introduce bone graft in the joint, then do distraction, fixation, and you give new life. And you give new life instantly, very quickly to these patients. And this is the beauty and wonderful kind of revolution in craniovertebral junction surgery. You see the facets completely non-aligned or malaligned, and you have completely reduced and changed the story of basilar invagination. Chronic atlantoaxial instability, chronic. When there is acute instability, there is pain here, this severe pain and all those things. But in chronic instability, when the instability is for 20 years, 30 years, there are several natural adaptation or protective maneuvers by nature, by God. The attempt by nature is to reduce the effects of instability. And in a chronic situation, there is more often central instability, which you cannot recognize on dynamic imaging. And I want to discuss this issue of central instability. And if you read this article, central instability can result in basilar invagination, Chiari malformation, syringomyelia, spinal degeneration, deformities, OPLL, Hirayama disease, and a number of issues. Chronic atlantoaxial instability is the primary issue, and this is what I want to discuss. chronic atlantoaxial instability for 10 years, 20 years, 30 years. All patients with chronic instability will have pain in the neck. All patients with chronic instability will have spasm in the neck muscle, big spasm. All craniovertebral junction chronic instability will have shortening of the neck. So short neck, short head, basilar invagination, Chiari malformation, syringomyelia, C2-3 fusion, clipal file abnormality, kyphosis, torticollis, bifid, osodontoideum, all these things that you are seeing here are all secondary to chronic atlantoaxial instability. Instability is the problem and stabilization is the treatment. If there is Chiari, you treat atlantoaxial stabilization. If there is Chiari with basilar invagination, atlantoaxial instability is the problem. If there is syringomyelia only, do atlantoaxial stabilization. If there is only C2-3 fusion, don't look anywhere, do C1, C2 fixation. If there is only bifid C1, do C1, C2 fixation. So atlantoaxial instability, chronic, has a lot of natural protection. And those protection, we always consider those protection as pathological and treat by decompression. I'm saying don't do decompression for any of these problems. Issue is unstable spine and stabilization is the treatment. So instability occurs at the facets. In 1999, we said that the basilar invagination is due to instability at facets, listhesis of C1 over C2, like lumbosacral listhesis. Listhesis or instability is the problem in basilar invagination. You will be surprised to know that before 1999 or before 1998, the whole world was treating basilar invagination by decompression. Nobody in the world was treating basilar invagination by stabilization. Nobody used to treat. So listhesis was introduced as the problem. Instability was the cause and stabilization was the treatment. So this was the patient I did in 1999. This was basilar invagination. There was Chiari, there was syring. Listhesis was the issue. Stabilization was the treatment. Realignment was the result. And most importantly, most critically and crucially, the patient completely new life after surgery, magically new life. Now you carefully look at these slides, very carefully. I have shown this slide several times. Takashi must have seen it several times. Please see again, because still it is difficult to understand for several, those who are not in this business of craniovertebral junction. So this is the atlantodental interval is increased here. Facet of C1, there is listhesis here. There is basilar invagination here. Instability is the problem. Listhesis is the issue. Stabilization is the treatment. So this is what we talked about in 1999. Now we say central instability. Central instability means there is no atlantodental interval problem. There is no atlantodental. There is no compression at behind the odontoid process. No compression. But there is listhesis of C1 behind C2. In this, there is in front. So there is a retrolisthesis. This is clearly unstable. Any kind of decompression, foramen magnum decompression, whether you remove the bone, whether you open the dura, whether you remove the tonsil, these are all negative treatment in the presence of unstable atlantoaxial joint. Difficult to treat. This is not easy to treat C1, C2 fixation, but that is the treatment, C1, C2 fixation. Another thing is when the facets are in alignment, when there is no atlantodental interval disturbance, when there is no compression, presence of Chiari, presence of syringomyelia, presence of assimilation of atlas, presence of platybasia, presence of all these problems, and a number of other problems like clipal file abnormality, assimilation of atlas, C2-3 fusion, bifid C1, bifid C2, So many other issues, short neck, torticollis, all these indicate unstable atlantoaxial joint, and stabilization is the treatment. So type 2 and type 3, I call it central or axial atlantoaxial instability. I must say that I have not yet heard any neurosurgeon or spine surgeon in Japan talking about this kind of instability for Chiari and for basilar invagination. Nobody from Japan, I have never heard. I have heard several people from China talking about it, several people from Egypt, from Turkey and other countries, and many, of course, from India, but nobody from Japan. So it is important for me to convey this message to Japanese neurosurgeons. And I would like to know if there are some people in the audience who have understood this kind of instability and treated the patients with this format. So basilar invagination, syringomyelia, Chiari malformation, they are all secondary to atlantoaxial instability. I wrote this article on Chiari, which is now very highly cited article on this subject, one of the topmost in the subject. We said that atlantoaxial instability is the cause of Chiari malformation, and atlantoaxial stabilization is the treatment. And now over the years, we have treated several hundred patients with only C1, C2 fixation, and no questions to be asked, no discussion to be had. C1, C2 fixation is the treatment for Chiari malformation. Any kind of decompression is a negative form of treatment. So central or axial, atlantoaxial instability can cause craniovertebral junction problems. Atlantoaxial instability can cause central instability, can cause subaxial like degenerative spine, OPLL, Hirayama disease, and other things. And it can be identified as a discrete, just nothing but central instability. So in my estimation, understanding of central instability has the potential to completely revolutionize craniovertebral junction surgery. So basilar invagination, atlantoaxial instability is the cause. Basilar invagination with Chiari or without Chiari. Chiari with basilar or without basilar. Instability is the cause, stabilization is the treatment, and I have written with my group several articles on this subject, and many of you must have, of course, read these articles. So this is Chiari malformation syringomyelia. Today, I will say 95% of the neurosurgeons or spine surgeons of the world will do foramen magnum decompression. And I have to tell you that decompression is a completely negative operation, not useless operation. It is now, with my experience, I will say it is a completely, I don't want to use any nasty word, but it is a negative operation. That is the best word I can use. So there is no atlantodental interval, little bit facetal instability, C1, C2 fixation. The syringe will reduce in 100% of cases, 100% if you do imaging after 1 year. And the patient will recover in the evening of operation. You can tell the patient before operation that this operation will give you not just some recovery here and there, it will give you new life after surgery. It will give you a completely different life after surgery. You can tell the patient before operation. So when there is basilar invagination, when there is assimilation of atlas, it does not matter if there is compression. It does not matter if there is a facetal instability. This concept of tight posterior fossa was introduced by me in 1998. But now we say tightness of the posterior fossa and neural structures is not the issue. Decompression is never the treatment. Instability is the issue, and stabilization is the treatment. This kind of basilar invagination, difficult to treat, no question. But decompression is not the treatment. I know when I grew up in Japan, there were many stalwarts in Japan, like Professor Hakuba, and several other top neurosurgeons in Japan. I'm forgetting the names. They were very, very good in transoral surgery. And now I'm not sure how much transoral surgery is being done in Japan. But it is never necessary. You can do stabilization, even when the compression retains. Don't worry about the compression. Don't have compression is not the issue in spine surgery. Don't keep on talking about compression. Learn stabilization and do stabilization. Syringe will reduce. Sometimes in very early phase of the postoperative, in 3 days, you can have syringe reduction. No atlantodental interval, little bit here, do fixation. That is the treatment. So this is immediate after 6 or 7 days of surgery, the syringe has reduced. There is no decompression, and this is after a period of time. So this is the result of syringe. And now I have got hundreds, not tens of 5 or 6 patients that I can show you. Hundreds of patients where syringes have reduced, and the patient has, I have given new life to these patients. These patients, you see, there is no problem here, no problem here. Look at the facet, look at the mobility, look at the spinal curvature. This curvature is there in almost quite a number of patients. You have deformities of spine in Chiari malformation. Don't start dealing with spinal curvature. Do C1, C2 fixation. So this is central or axial atlantoaxial instability. No problem here. You see type 2 atlantoaxial central instability. Facet is retrolisthesis. No problem here. No problem here. Don't do decompression, stabilization. Syringe will reduce. And the patient, of course, will improve dramatically. No problem here. No problem here. The 99% of spine surgeons or neurosurgeons in the world today will do decompression. I am saying doing decompression is a complete nonsensical operation in this. Learn the art of C1, C2 fixation and learn to how to give new life to these patients. So this was my article with nearly 400 cases. Now my experience is almost 600 cases of Chiari. And with this experience, I have no confusion. I have no doubt with fellows from all over the world, with number of my own students following this concept. This is the treatment of C1, C2 fixation. So compression is never primary. It is protective. It is a natural protection. Like in Chiari, it is like airbag. For an accident, this airbag is a natural protection. Once the accident is over, the airbag can disappear. So it is, one is protective, one is reversible. And it indicates that there has been a big accident. So there is a instability. I have stopped using the word malformation. I am now using the word Chiari formation. So this is tonsillar herniation or Chiari formation. Look at the huge instability at the facetal articulation. Learn how to do fixation. Tonsil will go up. Tonsil does not go up always, but syringe reduces always. Syringe here, no problem here, little bit problem here, syringe reduction, C1, C2 fixation. This is another case. I've shown you actually this one earlier. Reduction, problem here, no problem here, C1, C2 fixation. Similar to Chiari, similar to syringe, similar to basilar invagination, assimilation of atlas, C2-3 fusion, triple file abnormality, all these cervical fusions are secondary to chronic instability, and they indicate instability. No compression here. No compression means that is not the issue. It is unstable. These are secondary problems. You do stabilization and you can give a miraculously new smile to these patients, new breathing. This patient was not even able to talk before operation. You see the short neck. It is not easy to do operation. You see the charmness in this face as compared to this one. Much more stronger when you see C2-3 fusion. When you see C2-3 fusion, don't jump at this. Don't jump at this compression. Don't look at this compression. Look here at the facet. This is bifid. This is unstable. You have to do C1, C2 fixation. There is no need to do any subaxial fixation. So C2-3 fusion, assimilation of atlas, os odontoideum, and all these issues indicate atlantoaxial instability, more often of central type. Basilar invagination, bifid C1. When there is a bifid C1, it is not an embryological disorder. It is not due to this phase or that phase of embryogenesis. It is due to chronic instability. It is due to a chronically unstable spine. When there is bifid, it means there is unstable spine, and you have to do C1, C2 fixation. If there is bone fusion, if there is bifid, you have to do C1, C2 fixation. Os odontoideum is not an embryological problem. It is secondary to chronic unstable spine. You have to do C1, C2 fixation. This os odontoideum, you have to do C1, C2 fixation. Syringomyelia is not an embryological problem. In 1996, for the first time in the literature, we said that it is a natural protective phenomenon. It is not a pathology. Don't put shunts, don't put tubes, don't decompress. It indicates unstable spine, and you have to do stabilization. So there is a syrinx. If the syrinx is associated with Chiari, all right. If syrinx is associated with basilar invagination, all right. If it is associated with assimilation, C2-3 fusion, clipple fight, all these things indicate C1, C2 instability, and C1, C2 stabilization is the treatment. External syringomyelia, CSF outside the core. We introduced this new term, external syringomyelia. External syringomyelia is also like internal syringomyelia. It is also protective. It also indicates unstable spine. It also is reversible following atlantoaxial stabilization. So in this case, you see there is external syringomyelia. In this case, there is internal plus external. In this, there is more internal, less external. So there is internal and external syringomyelia. They both indicate unstable spine, and stabilization is the treatment. Short neck, torticollis, various kinds of neck deformities. These kind of short neck, torticollis, they indicate atlantoaxial instability. You stabilize. In the evening of operation, the neck can become long and it can become strong, and it can give a new life to these patients. So short head, short neck, short body spine, short posterior fossa, big spinal canal. So vertically compressed, horizontally widened are the hallmarks or are the features of chronic atlantoaxial instability. So if we learn how to treat, we can give beautiful smiles and make these children really fantastic. Like there is short neck, there is short spine. When there is short neck, there is torticollis. When there is short spine, there is kyphoscoliosis. When there is kyphoscoliosis, it can be due to atlantoaxial instability. You stabilize in the evening of operation, the neck will become straight, the neck will become long, the spine will become long, and the kyphoscoliosis will disappear, and breathing will improve, and the patient will get a brand new life after surgery. More often than not, in many of these cases of central or axial instability, the motor evoked potentials will improve up to 50 or 40% during when you tighten the screws of C1, C2. So this is Chiari malformation, no problem here, no problem here. I tighten the screw, the MEPs improve 40% during operation. Another issue is central or axial atlantoaxial instability can be present even when there is no compression here, no compression, no problem here, no problem here. Presence of bifid C1, presence of syringomyelia indicate unstable C1, C2, and this indicates central or axial atlantoaxial instability, and C1, C2 stabilization is the treatment. Hirayama disease, which is common in Japan, which has been introduced from Japan, we have said that central instability can be very important cause of Hirayama disease, and it can be associated with Chiari malformation and syringomyelia. So this is Hirayama disease, and nobody knows how to treat Hirayama disease. Many people do corpectomy, many people do laminoplasty. Do only fixation. Central instability is the problem. Include C1, C2, and you can give new hands to these patients. So my current concept is foramen magnum decompression can certainly become a historical operation. In my own department, We have never done foramen magnum decompression at least for 20 years or more, and this operation is certainly going to become historical. So thank you very much, my dear friends. And Takashi, over to you. I hope I could give some new messages to my dear friends in Japan.
Okay. Thank you. Thank you, Dr. Gore, for nice lecture. So, in Japan, so we have few experience to each institute have a few experience. In Japan, special situation of these cases are divided in orthopedic surgeons and neurosurgeons. So neurosurgeons have experience fewer experience. So that's why a Japanese neurosurgeon can do not aggressively for these cases, I think. So I would like to ask Dr. Gore. So you have some very many cases experience many cases and simplify the complicated parts and bird's eye view so to look down on those complicated concepts and simplify and wrote many papers in your experience. So I learned so much. So and I would like to visit Mumbai and directly learn, and many Japanese neurosurgeons contribute to more contribution to Japanese neurosurgeons. And thank you for the nice lecture, Dr. Goel.
Takashi, I have to inform you that from 2nd to 6th August, we are having about 30 Japanese neurosurgeons visiting India in
Okay.
Indo-Japan friendship meeting. And we are going to do live surgical demonstrations, live surgery demonstration on 2nd and 3rd August. And John, we will ask John to see if that will be possible to relay live on Neurosurgical TV. I'm sure he will be. John, what do you think you will be able to relay live?
Well, we always do the king's bidding. We
Okay.
we cannot disobey. I want to live.
Yeah, it's a great opportunity. Yeah, it's a little traveling to Mumbai is a little far, but from the Asian part, so I would like to travel because my son is in Singapore, so I will try to directly to go to India someday, so and learn so much from Dr. Gaur and Dr. Shah and other neurosurgeons in India. Are there any questions from the audience? Yeah, please go ahead.
Go ahead, Mohammed.
Mohammed.
Hello, good day, to everybody. Nice to see you and hear you again, sir. It's been a long time.
Yes, Mohammed. How are you? Everything okay?
Thank you very much. I am doing good. I'm doing very good. Thank you very much.
Am I going to see you in Mumbai or no?
Yes, I will come, but not for this time. I think it's going to be quite difficult for me. I'm sorry about it because of a visa issue, you know. I'm sorry about it. The embassy is opening just next week. The Indian embassy has been closed for some time, and they're just opening. They announced just 2 days ago the reopening thing, and then they will start from next week maybe to get some applicants, and it's going to be difficult, but I will do it. I will do it for some time for sure. Thank you so much. I hope it will be live though.
Yes, it will be live. The whole thing will be live on Neurosurgical TV.
I will ask a good question, so for the others to hear also. What do you think the future type of imaging to do for the C1, C2 instability?
See, as I've said, what has really advanced in neurosurgery is one is anatomical understanding, anatomy. We have learned anatomy over the years. Second thing which has advanced very dramatically is imaging technology, imaging.
Yeah.
Preoperative imaging and postoperative imaging and intraoperative imaging, like 3D CT scan, 3D models that I have talked about, and intraoperative navigation, intraoperative CT scan. On all those things are very important. So one is anatomy, one is technique, and one is technology. The most biggest thing about all this thing is concept and philosophy. So Understanding is important. Concepts are important. Philosophy is important. Thinking new is important. You see, Chiari malformation, Muhammad, still from in the whole world, still everybody. Whenever I talk, there is confusion, there is discussion, there is argument, and you have seen whilst you were here in India, no question, you give new life to this patient. Only thing is to do C1, C2 fixation in a case of Chiari, in a case of basilar invagination is not an easy surgery. It's a difficult operation. So you learn this difficult operation. Foramen magnum decompression, anyone can do. But C1, C2 fixation, not everyone can do. But if you can do, if you can learn, if you understand the concept, you want to follow the concept, like you are a young neurosurgeon, you came to India to see what I'm doing and what I'm not doing. And you have seen there are several senior neurosurgeons, from senior most neurosurgeons in pediatric neurosurgery, in neurosurgery, who have heard me and they have come and spent some time with me. And then they a little bit change here, change there. The thing is, first is you say, no, I don't believe this nonsense. I don't agree. That is not one easy way to get rid of it. Second thing is, I can understand that there might be some issue and I should learn this. Third thing is, now the world has become, of course, imaging has improved, technology has improved, the flights have become improved. You see, you can come from any country in 8 hours, 10 hours, you can reach any other country. There is no country you will reach more than 24 hours. It is not like you are going by ship or you are walking for 1 year coming. And the flights have become cheap. The question is, if you have the will, there is a way. If you want to understand, there is a possibility. If you really want to ignore what is, you see, you cannot ignore what is coming from elsewhere. You have to incorporate in your system and try to see if it is possible or not. You understand, Mohammed?
Yes, of course. You know that the one thing, the most important thing that I have learned when I came to India is all the symptoms are protective. All the symptoms that the patient, but it's difficult to come from somebody like me.
Symptoms are secondary.
Yeah.
Pathology is secondary. Problem is our own body. We have not taken care of our body, our muscles. We have injured our muscles. We have not delivered the baby. And we blame the embryogenesis. We blame the fetus. We blame that embryogenesis is faulty. You see, one thing I have learned in my career, or I have understood, that there is no terror of error in nature. The nature can never be wrong. You see, from a fetus, you cannot have any, cannot be a faulty birth. You cannot get an elephant from a human body or a fish from a human. There can be no error. It is a error-free. When nose cannot be made here, in the ear, nose cannot be put here. Have you seen nose coming out from the ear? So there is no terror of error unless then error is introduced by us humans. So that is the philosophy. Similarly, Atlantoaxial instability is the main issue in several. And I will talk on subaxial instability in my next lecture. And I hope, Takashi, in my next lecture, I want to talk about degeneration of spine. I want to talk of what happens in old spine. And in Japan in particular, many people in Japan are 80, 90, 100 years old. What happens to a 80-year-old, 90-year-old spine? It is not that 90-year-old spine can have problem. If a 90-year-old man is strong, he's running, he's keeping himself fit, there may be no spinal issue. But if a 90-year-old man or 50-year-old man thinks he's retired and he's finished, he will start getting issue. So it is very important that we understand our own body, take care of our body, and strengthen our body. So there will be no instability.
Okay. Thank you. So any other questions from the chat? I have the Dr. Rai Lehman and next Dr. Musaku Latif. Musaku Latif also have questions. Dr. Musaku Latif.
Assalamualaikum.
There he is. Okay.
Hello.
Yes, hi, welcome.
Welcome.
Hello. I
Yeah.
have um,
Go ahead,
I
go
might
ahead.
have some questions for Professor Dr. Atul Goel.
Yes,
But
yes.
the thing is that, sir, I'm a great fan of yours. I'm from Pakistan. I've been the student of my mentors are your students. Dr. Riaz Raja and Dr. Shams Raza Brohi are your students, and they've seen you at Mumbai.
Thank you.
So, I'm their student, and I had a few questions. Uh, what do you go for in children if the children have got issues like Chiari malformations? I'm talking about the children less than 2 years of age. Can we go for the fixations in them? Is there any option like that?
Yes, Dr. Latif, my answer to your question is yes. My answer to your question is definitely yes. You see, one thing I'll tell you. Chiari malformation, syringomyelia, and all these problems are due to chronic, not acute, chronic instability. In children, in 3 years or 2 years, it does not become chronic. So very rarely you have in children 2 years or 3 years. I think in my series, the youngest child may be 5 or 6 years old. I don't think I have ever had a 3-year-old child with Chiari. But if you have a 3-year-old child with Chiari, the symptoms will be more pronounced. Like these patients in 3-year-old child or a 5-year-old child will come with sleep apneas. He will come with breathing disturbances. He'll with the increased tiredness. He will come with difficulty in which the symptoms will be more pronounced and more aggressive. And you do C1 symptom, C1 C2 fixation, the recovery will be also dramatic. Means the patient who is almost highly crippled or unable to walk will start jumping. Means it will be a dramatic clinical recovery. So in children, of course, the pathophenomena is the same. The whole story is the same. And the treatment is also the same. So that is the answer to your question, Dr. Latif.
Thank you, sir. Thank you so much.
And Dr.
Okay,
Latif, I'm going to talk to Pakistan audience very soon. Dr. Noor
Inshallah, sir.
has contacted me, and I'm going to give a big series of lectures on neurosurgical TV, courtesy John Bennett, which will start in the next month. And Noor will be conducting this show. And I hope to give at least 7 or 8 or 10 lectures in a series. So let us see. I will be talking on skull-based tumors, cavernous sinus tumors, pituitary tumors, trigeminal neurinomas, colloid cyst, tuberculum celli meningioma, and all these petroclaval meningiomas. So let us see, Dr. Latif. I am coming to Pakistan very soon. After Japan, my trip is Pakistan. Okay?
I shall be glad, sir. I shall be glad to see you, sir. Thank you, sir. Thank you so much.
Thank you. Thank you.
thank you. So,
I hope one day you come to Libya.
Olivia. And other questions, Dr. Lai Lemon, so the chat. Dr. Lai Lemon there. So I read the questions learning a lot
Yes, yes.
from a variable lecture. Is available? Dr. Lai Lemon
Yes,
available?
yes. I
Go
can
ahead.
read that. Takashi,
Okay, I can read. So actually, they fear the screw will create complications, especially at C1 level. Please guide how to do safely, how the graft is inserted, what to do with C2 ganglion. Need information about size and trajectory of the screws.
I can only say that next
Okay,
week.
so several questions. So I will divide one by one. The fear the screw will create complications, especially at C1 level. Please guide how to do safely. The first question.
The answer to the question is that you have to know the anatomy of this region very nicely. You have to know You have to be experienced in controlling venous bleeding. There can be huge venous bleeding in the lateral gutter, huge. You have to know the anatomy of the vertebral artery very nicely. You have to know the location of the C2 ganglion very nicely. You have to know the screws. You have to know the plates. Because in neurosurgery, we don't learn about screws and plates and all those things. We don't talk of, when I started using plates and screws in 1987, at that time, the screws, nobody in the world knew screws. Even orthopedic people didn't know screws. What are screws? They were in the, radial fixation screws and things like that. So screws were not even born at that time in the field of spine and in neurosurgery. So understanding screws, understanding spine, understanding anatomy, understanding all these things are so critical and crucial and important. So it cannot be, I have conducted several live surgery workshops all over the world. And now next week, I am conducting one live surgery program in India where about 400 neurosurgeons we are expecting from different parts of the world. And we are having a big symposium on complex spinal cases, on complex brain tumor situation. And we are having a big program. I wish, Dr. Rahman, if you can come to Mumbai, I will take care of you. But you have to come. You have to take effort. And you cannot say, oh, this, oh, that. This is not an excuse. You cannot say, oh, I'm expensive, oh, difficult. Oh. In the current era, current world, nothing is difficult.
There you go.
When you have become a neurosurgeon, nothing should be impossible for you. You should say, yes, I can, and I will, I must.
The king has spoken. Okay, well, we have a neurosurgeon, neuroanatomist from China, Yandong Su. He looks like he wants to ask the question.
No, exactly. Because already I have listened this lectures hundreds of times.
Okay, thank you.
Yeah. Now, Professor Atul, now I'm still waiting for the visa result, but I think maybe it's difficult to have a successful visa. So maybe it's difficult for me to go to Mumbai next week. But I'm very happy that John will webcast the lab surgery workshop, and I hope I can broadcast the surgery workshop into Chinese people. And also, it's my strong recommendation to everybody to go to Lilamati Hospital and the Somaya Hospital to smell Professor Atul's operations. And I think everybody will see the magic. Yeah.
That must be quite a scene around the OR in Mumbai. I can imagine residents, students from all over the world. Fantastic. I think we have a friend from Afghanistan, Ahmad, that wants to say hi to you. Good day, Ahmad.
But
Salam alaikum. Namaste. Konnichiwa. Thank you very much. Thank you, Professor Atul Goel. Thank you, Professor John, Takashi, Professor all of our colleagues. Thank you very much. Great lecture and congratulations for your achievement. We follow your way and advice and recommendation, Professor Atul Goel. Thank you for you. And also we follow also Dr. Ubaida Shah as well. Thank you.
Thank you. Thank you.
Good.
You must make a plan to come to Mumbai.
But we haven't chance to get visa, Indian visa. We have very bad situation in Afghanistan.
Okay. Anyone else have a comment or question?
Any questions?
Cristobal, Manuel, do you have from Mexico? Do you have a comment or question?
Mexico?
Yeah, I believe.
Hello.
Yeah, go ahead.
Hello, Professor. Hi, how are you? Thank you for great lecture. I was just wondering, how did you manage a vascular catastrophe before neuronavigation?
That is very important. You see, you can have a catastrophe. You can have vertebral artery injury. You can have complications. This is a difficult operation, no question. But you know what? I must have damaged vertebral artery several times in my career, several times.
Okay.
But you know, when you damage, you immediately finish the vertebral artery. You know, if there is screw, if you put screw, there is a bleeding, you continue and complete your screw insertion. Don't wait for bleeding. Don't wait, because the other side vertebral artery will take over. I have damaged both sides vertebral artery also sometimes. So it is a difficult situation, and I have learned over, you see, I am doing this operation since 1988. And I have damaged vertebral artery before navigation. And I must tell you that I don't use neuronavigation now in all my cases. Very rarely I use neuronavigation. This understanding of the location, understanding of the, the imaging, the coronal section of CT scan, putting the screw right in the medial part is very important. And sometimes, you have to be very, I can understand that if you damage, you can have a problem. So you can give new life to the person, but you can kill the person also. Like in all kinds of neurosurgery. In brain tumor surgery, meningioma or any avian, you can give new life to the person, but if you don't do it properly, you can kill the person. So that is our life as neurosurgery and spine surgery and craniovertebral junction surgery. So we have to learn and we have to understand. But I have to tell you that complications can be very few because we are working outside the nerves. We are working outside the canal. So only one issue is vertebral artery. So protect it. That is the thing.
Thank you very much, Professor. We wait for you in Mexico.
Right. He's been there. We can go back. Okay, very good. Thanks everyone for coming. Thanks Takashi, and of course to the King, and thanks for all the panelists for making it a real interactive, the way it should be, the way Zoom should be. And I just want to say a little commercial here.
John,
yes,
John,
yes.
The next lecture to the Japanese neurosurgeon will be on the 10th or 11th August, right?
11 August, yes. So I will chair. So I'm looking forward to. Yeah.
What's the title? What's the title, Atul?
Degeneration.
Vertical spinal instability. Vertical spinal. I will give the title.
Okay.
Okay, just a quick commercial, Atul. Anyone that has a good neurosurgery webcast they'd like to televise, just write to me, JB@Neurosurgical TV. We'd be glad to hear from you. And once again, thanks again to the King.
Thank you. Thank you, Dr. Goel. I met Dr. Kobayashi last week.
He's okay?
Yeah, and he's okay. He's okay. He's giving the best regards to you.
Okay, Takashi, thank you. And
thank you.
Bye, Atul. Bye, Atul.
Okay, so 2 weeks after. So I'm looking forward to the August 11th.
Harshad is there for a quick comment. Harshad.
Hey, stick around.
Atul.
Go ahead.
Atul.
Yeah.
I am the one who is the part of your journey of craniovertebral junction. I have seen you when we were growing as a residents, and we remember you working with Ellen Crocard doing transoral, and then you have revolutionized the whole thing and made us to forget transoral and to do C1, C2 fixation. Right from 1986 onwards, I'm seeing you. And you have brought definitely a new concept in C1, C2, and even a spine surgery overall. And this is something called metamorphosis of your own technique of C1, C2. And you have done very hard work, no doubt about it. And you have brought up so many number of cases with excellent results. And wonderful technique you have got. And I've seen you operating, and you can see the C1, C2 even in presence of blood. So it doesn't matter to you whether bleeding or not bleeding. You can still put the screws. Means I feel you are sleeping and you are putting screws inside. Your anatomy is so perfect of C1, C2. Wonderful job. And today also I felt, even though I've heard you so many times, but every time I feel it is so first time I'm listening to you. Superb, superb.
Thank you.
Wonderful.
Thank you. Thank you for your companionship.
Any other,
years.
any other closing remarks?
Doesn't
Okay, we'll see you when we see you, Atul. You'll be on the net a lot, it looks like, in the next couple of weeks. And
Yes, yes.
we're glad to
Bye-bye.
televise them all and put them in
Bye-bye.
your lengthy archive.
Yeah.